Okay, so first I want to say thank you, everybody, by the all here. And I can see people from different walks of life want to special tribute to the living legends. That is what we got last. But firstly, have the oncology legend itself. And we also have Kingham, Sloan, thousands of Wale. Know what Wale is? And I look forward to a very exciting afternoon. The lecture will not only study, but there's also something that is going to be happening today. Peter, I don't want to steal Peter's thunder, and I want that video one. What I can say is that oncology, as it is known, is entering a new phase. That's true. I leave that to. But I must also use this opportunity to acknowledge one man, Dr. Isaac Alatishe, who leads ARGO and has been exceptionally instrumental in what we're having. I remember about 3 years ago, I chased him to his theater, to his operating theater room in Ife, that this must happen. That we cannot afford to let things like that. Chase Peter, New York, everywhere, and I'm grateful. And I just remember that maxim that says, no, you're beginning the small. It's your latter end. We haven't seen anything yet. And like I said, I'm not going to stay. And over to you. Thank you.
Thank you very much. That was the CEO of Medserve, Dr. Adewale, gave a very brief welcome address. I want to welcome all again to this event, and we go on by having the lecture straight away so that we keep time. We want to be out of here by because we have other commitments and don't want to keep anyone to wait. So right now we go straight to the lecture that we have, and I'm going to be reading a very short bio. We go straight to the lecture that we have, and I'm going to be reading a very short bio of Dr. Peter Kingham. Dr. Peter Kingham obtained his undergraduate degree at Yale University and MD from Stony Brook Medical School. His general surgery residency was at New York University, and he undertook a research fellowship in hepatic immunology at the Matthew Laboratory at Memorial Sloan Kettering Cancer Centre. After finishing his residency, he completed a 2-year fellowship in surgical oncology at MSK, prior to being appointed on the Hepatobiliary service. He's currently assistant director to the Hepatopancreatobiliary Fellowship and director of the Global Oncology Fellowship. In 2015, he was appointed as director of Global Cancer Disparity Initiatives, and in 2020 he was promoted to the rank of a professor. His primary research interests are determining how to improve cancer care for patients in low and middle income countries, and building TB surgery in low-resource environments, and colorectal cancer liver metastasis management. Dr. Kingham is a co-PI on multiple prospective studies in Nigeria, co-founded the African Research Group for Oncology, ARGO, and he's the president of Surgeon Overseas. He's also a PI of the UG3/UH3 and the ROI NIH grants focused on colorectal cancer in Nigeria. He is a D43 NIH grant to build a cancer research training program in Nigeria, and a P20 grant to build an immune oncology cancer in Nigeria. He has over 300 publications in peer-reviewed journals and has authored 18 chapters. Please put your hands together with me as we welcome Dr. Peter.
Thank you very much for the warm welcome. This is the end of my this week-long trip here in Nigeria. It's always a fantastic time when I can come back home to Nigeria and see all my friends and colleagues here, and especially to be able to talk today about colorectal cancer, because it's something that me and all of our group are so passionate about. I have no conflicts except one. I played high school soccer, and that became known in Nigeria. And when I am not a surgeon and a researcher in New York or in Nigeria, this is how I spend my time. You have to look down on the bench, but I'm seated at the end of the Nigerian national team, wearing my proud green and white jersey. So we're going to talk about colorectal cancer. It's really a growing problem around the world. It's predicted that relatively soon, the majority of colorectal cancer patients will live in low middle income countries. And this is not a random photo. This is actually a photo that's about maybe 13 or 14 years old. This is about a 25-year-old. It's 2 a.m. It actually was in the Mission Hospital in Ife, because if I remember right, Isaac, the University Hospital was on strike. And so it was 2 in the morning, and this young man, he's quite skinny, but you can see his abdomen is really distended because he had an obstructing rectal tumor. So Isaac called me, and at 2 in the morning, we did a diverting colostomy, and we found he had peritoneal metastases. And they looked and felt different than the metastases that I'm used to seeing. I unfortunately see a lot of metastatic disease in my job in New York. And this pattern of a 25-year-old, this is not a common pattern for me to see. And Isaac said, actually, we're starting to see more and more of this. So this one young patient actually started us down this path of trying to figure out who's getting colorectal cancer and why, and what can be done about it in Nigeria. So we started the African Research Group for Oncology Consortium, ARGO, focused on research, training, treatment, and outcomes to try and improve outcomes for cancer patients, perform clinically meaningful research, create a model that can be replicated elsewhere, and for career development. So a little bit of background. The first thing we started doing was prospectively collecting data so that there's no model data from outside Nigeria or West Africa. There's actual data from Nigerian patients. And the first thing that was pretty obvious is, compared to the data I had access to in the US, much more common to have stage 4 disease in Nigeria than the US. And we'll get into early diagnosis and screening, because that's obviously what this is really showing, is so many patients come in late with late stage disease. It doesn't really matter what your treatment is at that point. It's very hard to cure a patient once they have advanced disease. And we started collecting baseline data on what happens to patients after they present. And these baseline data are vital, because without these data, you can't do any intervention, because you don't know what the baseline is. You don't know if your intervention has actually helped. And the 12-month survival for all comers was less than 50%. And this really represents the high number of patients coming in with late stage 4 disease. So one of the first questions we asked was about epidemiology. Who are the patients who are coming in with colorectal cancer? Because we knew that what I say is the epidemiology of colorectal cancer in New York tells there'll be overlap here in Nigeria, but there's also probably unique factors here that's leading to this rise in colorectal cancer. So we asked this question and we got funding from the NIH to do a case control study. And we're just about done, 600 cases, 1,200 controls, spread throughout about 8 centers now. And one of the obvious things is this change in lifestyle. So rural Nigeria versus, I would say Lagos today, but traffic seems to have disappeared in Lagos. It took us 3 hours door to door from Ife to Lagos. So, but the idea of urbanization, traffic, smog, sedentary lifestyle, processed foods, all of this comes with urbanization and what people would call development, but it also brings breast cancer, colon cancer, prostate cancer, and these types of cancers. So we worked on a diet and exercise assessment based on the Nurses' Health Study from the US, and we converted this to a Nigerian version and validated it with food diaries and photo documentation. You'll recognize a lot of these foods, so it's specific to Nigeria. And this is allowing us to look at things like dietary patterns in people who do and don't have colorectal cancer. And we have a couple of Nigerian epidemiologists working on this because almost all of these studies have been done in high-income countries, and then everyone says, well, this is what it was in Western Europe, so this must apply in Nigeria. And obviously that often is not true. And most people have studied on isolated nutrients or food types, but people eat in patterns, right? I probably eat 80% is the same thing every week. And so we really looked at dietary patterns here using 3 patterns: diversified, African traditional, and westernized. And we found that the westernized dietary pattern increased colorectal cancer risk in all the models and stratifications of our analysis. And this goes along with urbanization, processed foods. So it's hard to read all of these, but there are patterns that people are eating in, and this westernized dietary pattern clearly is associated with colorectal cancer. So now the epidemiologists are developing some educational interventions on how to spread this word out to patients, and we're going to study these interventions to see if they help. As part of the study, we also asked about awareness of colorectal cancer. You can see all the way over on the left, that's awareness of breast cancer. And there's been so much focus on breast cancer, and that's a success. That's a success story. It's very common for people to know about breast cancer. The same is not true for many other cancers. Colorectal cancer, 23% of the people in the study were aware of colorectal cancer before the study. We also did an exploratory analysis where this is fascinating. We got a pilot grant for just 60 patients, and they wore a silicone wristband that was coated with a sticky substance. So you wear it for a week, and it captures everything you're exposed to. And anywhere I talk about this, anywhere in the world, everyone says, I want that. Doesn't matter what country you're in. We all want to know, what are we exposed to at home? Because there's a lot of things we don't realize. We did this as a proof of principle. Let's show that the bands can be bought in the US, the sticky substance can be applied, you can send it to Nigeria, people will wear it for a week, return it, goes in a fridge, goes back to Duke University, and they analyze it. We just wanted to prove that this process works. But we also looked at the data, and actually there are significant differences, even in this small pilot, between the cases and the controls on exposures to organophosphates, polycyclic aromatic hydrocarbons, and pesticides. The top 2 ones are often present in smoke with indoor cooking fires. So clearly some differences early on, and we're going to write this into a much larger study to really see, and this wouldn't be colorectal specific, because obviously these risks can apply to other cancers, breast cancer, prostate cancer, et cetera. We've also been interested in the molecular characterization of Nigerian colorectal cancers. And Isaac and I did a pilot study of 64 Nigerian patients, compared them to a number of our patients at Sloan Kettering. And we were very focused on mismatch repair deficiency or microsatellite instability. I'll call it MMRD in the talk. And we found 28% of patients had this marker. And this is significant. It's 2 to 3 times higher than what's reported. At Sloan Kettering, our percentage is about 8%. The Cancer Genome Atlas is 14%. So this is strikingly high. And it's not just of academic interest. This is really clinically relevant. We'll talk about this in a few minutes, because these are the patients who respond to immunotherapy and don't respond well to traditional 5-FU-based chemo. So Isaac and I show patients to each other all the time. And sometimes he'll see our Sloan Kettering patients. They get 5-FU-based chemo, and they have almost a complete response in their rectal tumor. And he says, I don't see that nearly as commonly. And it may be because he has so many more microsatellite high, these MMRD patients, and the chemo just isn't effective on these patients. We also looked at common mutations in the mismatch repair proficient Nigerian patients. The first one is this WNT pathway. The third one is RAS. We found significant differences between Nigerian patients and American patients. And it was interesting because we could split out African Americans, and they sort of fell in between. A lot of the African Americans in New York are of West African heritage originally. So there's this sort of in-between phase that they're in. And this is relevant too, because these mutations can also determine what chemotherapies patients are eligible for. So all of these data are really pointing towards the importance of early diagnosis. And this is something that we've spent a lot of time thinking about, because colorectal cancer can be considered a preventable disease. It starts from a normal colon, goes to a polyp, then goes to a colon cancer when the polyp grows uncontrollably. And if you can find it early enough as a polyp and take the polyp out, then you can prevent the progression to colorectal cancer. But there's two different ideas in colorectal cancer screening. So one is preventive screening, and the other is early detection. And we focused on both, and I'll sort of walk you through the studies. Preventive screening is you're trying to find the polyp before it turns to a cancer, and you're trying to remove it. Early detection screening means you can't reliably detect the benign cancer precursors, but you're trying to find invasive cancer at a much earlier stage, stage 1, stage 2, or even stage 3, prior to stage 4. So you have the opportunity of trying to cure patients. So there's a lot of challenges in screening in Nigeria and other low middle income countries. Most guidelines are based out of high income country data. And again, it's hard to apply those in a totally different setting. And there's all sorts of models that have been made about how to predict who's high risk, who's low risk, who has a polyp, how often to surveil them. But all these are based off of high income country data. So there's no really context-specific data to guide recommendations here. And there's so many different options. There's fecal occult blood testing, there's fecal immunochemical, there's FIT DNA, Cologuard, there's blood tests, CT colonography, sigmoidoscopy, colonoscopy capsules. So there's a lot of options. So it gets confusing. What's the best way to try? So we broke this down into average risk people, first-degree relatives, and patients with symptoms. And we've looked at FIT stool-based testing, a clinical screen, a urine metabolite test, and a blood methylation panel. And I'll talk you through some of the data on these. So we started by doing early diagnosis, not screening of an average risk person. And we were criticized by people saying in high income countries, it is so effective to look in the stool. Why aren't you doing this? You have to do this in Nigeria. So Isaac gets a lot of credit for this because during COVID, he accrued over 2,000 patients. These were asymptomatic average risk people, aged 45 to 75, in 3 Nigerian cities. 91% returned the stool sample. 21% were FIT positive, which is much higher than we see in high income countries. And about 2/3 completed the recommended colonoscopy. And what we found was that there was a very high false positive rate for Nigerian patients. And the positive predictive value for invasive cancer was actually very low, 1.1%. And for advanced adenomas was 7%, which is also very low compared to high income countries. So most of the false positives were from internal hemorrhoids and diverticulosis. So in the end, we concluded that FIT, at qualitative FIT, 50 micrograms per ml, it's the highest on the market and point of care. False positives were just too big of an issue, and especially where resources are scarce, colonoscopy, not so easy to access everywhere, and it's self-pay. This is really an issue. It also may be that the incidence just still isn't high enough here to do asymptomatic screening. It also may be that the pathway of how normal to cancer happens in Nigeria is different than this traditional pathway that I showed you before. We don't know the answer to these things. But what was clear was that this qualitative FIT at 50 micrograms per milliliters, really hard to recommend that for average risk screening. So something else we focused on is how do we find the patients who are at highest risk, the symptomatic patients. So if the Minister of Health asked, who should get a colonoscopy in Nigeria, who would those patients be? So we did a study of 362 patients, more than 45 years old, with more than 1 week of rectal bleeding, and they all got examined and they got a colonoscopy. And this was a training cohort in Ife and then a validation cohort in 2 other cities. And you can see that it was the same between all three cities. We found about 20% of patients had cancers and 78% had polyps. Now, these are high numbers, so this doesn't apply to every person walking around with a little rectal bleeding. There was a lot of selection on who actually came in for this study. But it gets at, we can use some characteristics of a patient to try and identify who's high risk. So we built an algorithm using weight loss, change in stool, created a point system and probability to try and really figure out who is the highest risk for colorectal cancer. And then we asked, are we just finding stage 4 patients, a couple of months before they were going to walk in the door? Because that wouldn't help survival. But when we looked at the stages, the majority were stage 2 and 3, and the minority were stage 4. So this is what I showed you before. In our database, currently it was 54% stage 4, and that dropped to 26%. If this was a drug trial, a pharma company would have the lead talk at ASCO with a stage 4 drop from 54% to 26%. So I think it's really important to think about this idea of using clinical signs and symptoms to try and identify patients early. When I talk about, sometimes I talk about as clinomics, because if you don't have omics after something, nobody wants to talk about it. We have genomics, everything's an omic, proteomics, and so this is clinomics, using the clinical features of a patient to try and find high risk. So we asked ourselves, can we scale this up to an early diagnosis program that's much larger? This was just a pilot at tertiary centers with the goal of decreasing delays in diagnosis and increasing early diagnosis, because often what we found when we asked patients was they had actually presented multiple times into the healthcare system, but they weren't moved along because there wasn't the suspicion of colorectal cancer. So we built the pragmatic trial. This is proposed for Ocean State with the Ocean State Ministry of Health with patient navigation. And it's triggered with someone over 25 years who has abdominal or anorectal mass. If you're over 40 with rectal bleeding and any of these symptoms, or over 40 with one of these other factors. And this we submitted as an NIH grant. You may have read that we had a change in presidency a month ago, and there's a ton of disruption right now in our NIH system. So unclear that we get funded from the NIH, but we're hoping to be able to move forward with this, because this would be a randomized trial in the state, Ocean State, 30 LGAs, and over a 4-year period, LGAs would randomly be entered into this. So you have pre and post intervention with patient navigation data. This would be a first of its kind trial anywhere in the world in a low middle income country. Thailand has done a little bit of this. No one has done a study like this. The WHO is eager for this. This would really be a groundbreaking trial. So hopefully we're able to proceed with it. Now, let's go from clinomics, which is very basic, to high tech. We've also always been looking out for, is there some way to leapfrogging, develop some point of care test? So we got an NIH grant that is based off of studying patients' urine to look for metabolites to diagnose colorectal cancer. So the first part of the study was 650 Nigerians, all had colonoscopies, proving what they had in their colon. The urine was shipped to Edmonton, Canada, and they did mass spectrometry, and then they started developing a handheld device. Isaac and I visited them in Edmonton. I actually brought Isaac to Edmonton, Canada, which is high northwest Canada. I brought him there in January, because if I have to suffer in the heat in Nigeria, Isaac had to suffer in the minus 30 temperatures in Edmonton, where you have to wear 2 jackets inside, but he survived. So the Canadians were working with us, and they found metabolites associated with colorectal cancer diagnosis. They quantified 142 metabolites in 514 Nigerian patients, and in the end, it was these 3 metabolites: diacetylspermine, hydroxyhippurate, and glutamate were the best metabolites. And basically, on the left there, that top line there is diacetylspermine. And that was the strongest association with colorectal cancer, glutamate next, and hippuric acid. And when we studied these, mixing them in with some clinical features like weight loss, you can see these curves show there was very high correlation with diagnosing patients with colorectal cancer. And to be honest, as the clinicians in this, both of us will tell you, we did not believe this would ever become a functional point of care test in Nigeria and be accurate. This grant was 5 years. It took us 8 years. We kept trying to get extensions. Working with a new tech company is very frustrating, especially when COVID hits and they lose their personnel and supply chain, all these things. But they did end up developing a point of care test, and it You collect the patient's urine and clinical information. It automatically processes urine, does the metabolite reactions, runs the 3-color reactions, and then it connects to a tablet app, which runs an AI algorithm to say yes or no colorectal cancer. So they did get to the point, years delayed, but we got to the point. And this is in Nigeria. So the device came to Nigeria, and then we did a 75-patient pilot. Again, we assumed there is no way this is going to be accurate. This is too hard to believe that this will work. So it was 38 controls and 37 colorectal cancer patients. And we set the specificity at 50% ahead of time. The sensitivity was 95%, which is actually much higher than what our goal was. We went over these data for months and months and months because we didn't believe it, which I think is good. As the clinicians working with technology, it's good to be very skeptical. Our job is to be skeptical, and the technology has to prove itself. You know, we're not salespeople for this technology. We're testing it. So we have now applied again to the NIH for a much bigger grant to really build this into a fully automated system and do a 650-patient trial. So fingers crossed the NIH moves forward, because this was a shock, and it may be that something like this is developed for the first time with Nigerian patients. Additionally, we looked at technology of a blood methylation panel, and this is a grant that's going on right now. The Gene Expert System, some of you may be familiar with, it's in most hospitals in all across Africa, originally usually from PEPFAR for tuberculosis diagnosis. And now they have cartridges that can help diagnose lots of other diseases. There's one for breast cancer that's pretty impressive that can look at ER, PR, and HER2. And our grant is, can we take blood tests from high-risk colorectal patients and diagnose colorectal point of care with a blood test? Cepheid is the industry partner. The clinical team is here in Nigeria. The PI is at Hopkins, and we're collaborators from Sloan Kettering. So more to come on this. So I will move for the last portion to updates on treatment. As was mentioned earlier, immunotherapy is really starting to change the face of cancer care. And now there are really 4 pillars of cancer therapy, not just 3. Chemotherapy, radiation, surgery, the 3 traditional pillars, and now immunotherapy added in here. On the timeline here, immunotherapy really started in the 1890s with Coley's toxins. They took bacterial toxins. They took bacteria and injected bacteria into tumors, and some tumors responded. Now, there was a lot of enthusiasm for this in the 70s and 80s. Then there was a lot of skepticism where the larger trials weren't working, but now there's obviously been this whole rejuvenation in the field of immunotherapy that is changing the face of some cancers. And I think that's what's important to know, is that some melanoma, renal cell cancer, these very immunogenic cancers completely changed it. Pancreas cancer, really very rare that it has any effect. So it really depends on the cancer type. So how did it come about to do this PD-1 blockade for treatment of colorectal cancer? The first real study was published 2015, and this is looking at MMR proficient and deficient disease. So this was asking the question, you look at everyone with colorectal cancer, what happens when you treat them with PD-1 blockade immunotherapy? It was 41 patients. Group A had MMR deficient colorectal. Group B had MMR proficient colorectal. There was a group C that was non-colorectal patients. And the disease control in the MMR deficient or microsatellite unstable patients was almost 100%, 90%, versus 11% in the MMR proficient. So this was the first study that showed immunotherapy can work dramatically in the MMR deficient patients and doesn't work in the proficient patients. And what this figure is showing is the biochemical response, where the blue is the MMR deficient, where all of them had this massive drop in things like CEA, versus the red where it all rose. And so this showed that MMR is a biomarker for PD-1 immunotherapy blockade. Then there was the Keynote 164 trial. So this was treating with Pembro in 124 MMR deficient stage 4 colorectal patients. Some had 2 or more prior treatments, rounds of treatment with chemotherapy. Some had 1 or more. And overall, the response rate was 1/3 in all these patients. The overall survival, though, was really high. These are all stage 4 patients. In the patients who were already heavily treated, overall survival of 31%. In those that it was given earlier, it didn't even reach the overall survival in this trial. So the conclusion from this was PD-1 blockade immunotherapy improved survival, and it may be more effective if it's used earlier. So the next trial looked at it as first line to see if it's used earlier, what happens. This is a phase 3 trial, 300 patients with MMR deficient microsatellite high colorectal, all untreated, randomized to chemotherapy versus the immunotherapy. And you can see the split in these curves with the immunotherapy progression much improved compared to the chemotherapy patients. So this was the definitive study that then showed that immunotherapy is superior to chemotherapy first line in this subgroup of patients. And we care so much about this because I showed you the data earlier where almost a third of Nigerian patients fit into this MMR deficient category, which is really a remarkable number. Now that's all in stage 4 patients. And when Isaac and I did these data that showed the microsatellite instability was so high, we thought, how could we do an immunotherapy trial here? While this was happening, colleagues of mine at Sloan Kettering from our medical oncology and colorectal group published this study that came out 2 years ago in the New England Journal of Medicine. And this was on advanced rectal cancer patients, MMR deficient, and they were treated with all previously untreated, and they were all treated with dostarlimab, which is immunotherapy. And the overall response rate was 100%. This was a bit of a surprise. They did not think it was going to be this impressive. And you can see visually that tumor at baseline at 3 months, and then at 6 months, the tumor's gone. It goes from PET avid to being nothing in the rectum. And in the end, none of these patients were treated with chemotherapy or radiation or surgery. So this was quite remarkable and led us to think, all right, instead of just thinking about stage 4 patients in Nigeria for immunotherapy, what about locally advanced stage 2 and 3 rectal patients as well? And so this is what Dr. Tolu was referring to earlier is we've spent the last couple of years with a great collaboration between MSK, ARGO, Medserve, and Beijing drug company to create this immunotherapy trial in Nigeria for these patient groups. Stage 4 who are MMR deficient and locally advanced rectal stage 2 and 3. And this is going to be in a 2-arm study. Originally, it was just going to be the stage 4 patients, but when we saw these data come out of my institution on the rectal cancer, we immediately added in that group as well. So the primary objective is to estimate the overall response rate in patients with treatment-naive metastatic